The first step selects the incision site. Two straight lines are drawn superior and lateral from the midpoint of the pubic symphysis. The index and middle fingers are then placed against each line, and a 4 cm horizontal incision is marked from the intersection point of the index fingers. Incise the marked skin down to the level of the subcutaneous tissue. If present, identify and cauterize the superficial epigastric vein, which will be present in the majority of patients. Continue sharp dissection to the level of the external oblique aponeurosis. Using diathermy, open the aponeurosis, exposing but not rupturing the underlying internal oblique aponeurosis. This will ensure the correct tissue plane is identified and maintained. Digitally dissect the space underneath the external oblique aponeurosis, sweeping laterally and cranially up the superior iliac spine, and then medially down the inguinal ligament to the pubic bone. This completes this step of the procedure and provides access to the posterior wall of the inguinal canal. Identify and mobilize the spermatic cord from the posterior wall of the external oblique aponeurosis. Elevate the cord up and out of the incision site and isolate with a surgical loop. Digitally explore the transversalis fascia down to the pubic bone and obliquely enter the space of retzius. This can be done by either digitally dissecting through the fascia or with the use of an appropriate surgical instrument to gently spread the fibers before digitally penetrating through the transversalis fascia. Using blunt forceps, guide a large 20 by 20 cm moist sterile gauze down the index finger into the space of retzius. No digital dissection of the preperitoneal space or space of retzius is performed during the Onstep technique. If an indirect hernia is identified, reduce the sac and contents and ligate or remove the excess sac as appropriate, according to general surgical practice. If a direct hernia is identified, it will be repaired with the placement of the polysoft hernia patch. In the case of a direct hernia, always ensure there is no indirect hernia present. Cut a horizontal slit in the polysoft hernia patch between the interrupted ends of the memory recoil ring, down to the apex of the curved notch of the patch. Do not cut the memory recoil ring. Place the inferior tail of the polysoft hernia patch under the spermatic cord, so that the tails are pointing lateral. Place 3 non-absorbable interrupted sutures into the hernia patch to join the prosthetic tails together. Please note, this technique is tension-free and no sutures are placed into the tissues to fixate the polysoft hernia patch. Remove the sterile gauze from the operating site and return to the scrub nurse. Grasp the medial apex of the hernia patch with 2 index fingers and insert obliquely into the space of retzius under the pubic bone, leaving the tails of the patch outside the incision. Digitally explore the medial portion of the patch to ensure it is fully deployed within the space of retzius. Insert the lateral tails into the previously dissected space under the external oblique aponeurosis, and digitally smoothen the tails of the polysoft hernia patch to ensure they are lying flat. Close the external oblique aponeurosis and skin with the suture type and technique of choice.